Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication: Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Hi, everyone. I'm Dr. Barry Bertolet. I'm an interventional cardiologist in Tupelo, Mississippi, and I'm here today to present a case to you. This is a typical case that you might use with Aggrastat, but in this is a case in which we develop an intracoronary clot or thrombus during the PCI procedure. Now, this video is really being produced really as a guide for fellows as well as those who may not be used to the contemporary use of 2B3As in practice. So my disclosures are very few, but also I've been asked by Medicure to present some cases and to share these with you. And with that, I have received some financial support to develop these videos for you. So we have a 57-year-old man who has a remote history of coronary disease. He's had bypass in the past. He's had 3-vessel bypass in 2000, so old bypass, having some increase in shortness of breath. We do an echocardiogram on him, and his ejection fraction is 35%. We also did a cardiac PET scan on him, and this came back abnormal, which then prompted our cardiac catheterization. So during the cardiac cath procedure, I'll go through those videos in a minute, but prior to the cardiac cath procedure, he did have a history of atrial fibrillation and was on oral anticoagulant therapy with Eliquis. And so this was held for 48 hours prior to the procedure. So on the angiogram, what we saw was he had a patent pneumograph to the LAD. He had a focal high-grade stenosis in the mid portion of the circumflex artery, and that vein graft to the circumflex artery was completely occluded. So here is that video. As that's playing, I will also let you know that the native right coronary artery, as well as the vein graft to the right coronary artery, were chronically occluded. And we felt that this circumflex territory was the best area for us to go after to try to improve his clinical situation and ejection fraction. So we proceeded with PCI of the circumflex by proceeding initially with balloon angioplasty with an intention of placing stents within the circumflex artery. So that was the plan. However, after the initial angioplasty of this blood vessel, we noticed that there was concern for clot and dissection within the circumflex artery, as shown in this video. This is a reversible antagonist of fibrinogen. It binds to the glycoprotein 2B3A receptor, where it blocks the final common pathway to platelet aggregation. It has a 2-hour half-life, which is quite useful, because we're not really anticoagulating the patient that long. If they have to turn it off because of a bleeding complication or they're going to surgery, then we can turn that off and it's not coming around. Platelets return to normal function within 4 to 8 hours after we stop that infusion. So the nice thing about Aggrastat is that it causes a very rapid and potent platelet inhibition and has a constant response for our patients. And so we know it's very predictable from case to case to case, and that's very nice. Importantly, through its mechanism of action, Aggrastat has the ability to disaggregate existing thrombus, which really is the crux of this case. We got thrombus and dissection is present, which is propagating thrombus, which neither an anticoagulant like heparin or any other thienopyridine could do. There are limitations what can cause a clot to disintegrate, but typically this is only a fresh thrombus that will break apart when we provide a medication to cause that release. So back to our case. This is how I decided to proceed in this particular case. Because of what I believe to be clot in this angiogram, as well as the dissection that we saw in the coronary angiography, we administrated a bolus of Aggrastat at 25 mics per kilo. With some difficulty, we had to use a guideliner here, is a 2.5 by 23 as well as a 2.25 by 15 Zions stent that has been placed within the circumflex artery, propping up the dissected area, restoring tiny flow within this artery. It's shown on this video. The infusion of Aggrastat at 0.15 mics per kilo per minute was maintained for a 2-hour time period, which allowed us to load clopidogrel into this patient. The patient was discharged home on triple therapy that was aspirin for a 1-week time period, ongoing clopidogrel for a 1-year time period, and then resumption of his apixaban therapy. Here are some takeaways from this case. Aggrastat can be used in a rescue mode. In this case, treatment of a locally formed thrombus after a PCI-related dissection, Aggrastat has the ability to disintegrate or disaggregate a fresh thrombus, one of the few and only drugs that can do that. Furthermore, after we were able to make the clot go away, we were able to cover this area with stents, which then decreased the chances of clot formation. And then finally, the Aggrastat provided a nice continuation from the end of this procedure to the onset of an oral drug, so that we had continuous antiplatelet effect that prevented the reformation of any clots. So I hope this was an illustrative case for you. Thank you for watching.